Welcome, everyone. On behalf of Centers for Medicare and Medicaid Services, CMS Division of Tribal Affairs, I'd like to welcome everyone to an All Tribes Consultation webinar. My name is Michaela Holm, and I work for Kaufman and Associates, and I'll be your moderator today. Today's webinar is titled IHS Payment for High-Cost Oncology Drugs OPPS Rule. Please note that this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. And I'll pass it on to Beverly Lofton.
Hi, everyone. I'm Beverly Lofton. I am a senior policy advisor in the CMS Division of Tribal Affairs. This webinar is in collaboration with the CMS Division of Tribal Affairs and the CMS Center for Medicare. During this webinar, presenters will provide an overview of two important recently proposed provisions. CMS is seeking comments on CMS's proposed revised payment policies to increase access to certain high-cost drugs for tribally owned and Indian healthcare services hospitals. Also, CMS is requesting information in order to evaluate a CMS Tribal Technical Advisory Group's request for CMS to amend its Medicare regulations to make all IHS and tribally operated outpatient facilities and clinics eligible for payment at the IHS Medicare outpatient all-inclusive rate. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website, and that website can be found at go.cms.gov/AIAN. The website link will be added in the chat. And we are pleased to be joined on this webinar today by David Rice and Sarah Sherry Lasso, Sherry Lasso, sorry, from the Center for Medicare, and that's CMS's Center for Medicare. So I will now turn it over to David to begin today's webinar. Thank you.
Thanks, Beverly. Okay, so just quickly to go over the agenda. And hi, everyone. I'm David Rice. I'm the director for the Division of Outpatient Care in the Center for Medicare. To go through what we're talking about today, we're going to talk about the current IHS payment policy for outpatient drugs, a little background on this proposal, and then go through the payment methodology, the proposed threshold, what drugs would qualify under this proposal, what the payment amount would be, how we would implement the proposal, and then some additional comment solicitations we've made as part of this proposal. Then I'll pass it over to my colleague, Sarah Shirey Lasso, to discuss the request for information on the IHS AIR. So just for a summary of the drug policy proposal, in calendar year 2024 OPPS ASC rulemaking, due to health equity and beneficiary access concerns, we solicited comment from the public on additional payment approaches that would enhance our ability to provide equitable payment for high-cost drugs and services provided by IHS and tribal hospitals. Commenters on that proposed rule, including tribal facilities, the CMS Tribal Technical Advisory Group, organizations representing tribal healthcare providers, pharmaceutical companies, and other interested parties expressed universal support for establishing a policy that would allow IHS and tribal healthcare facilities to receive separate payment outside of the all-inclusive rate for high-cost drugs. Based on the responses we received in this 2025 OPPS ASC proposed rule, we're proposing that we would separately pay IHS and tribal hospitals for high-cost drugs furnished in hospital outpatient departments through an add-on payment. This payment would be in addition to the all-inclusive rate. Next slide, please. So the current payment policy for drugs, under current regulations, IHS and tribal hospitals are excluded from payment under the OPPS. IHS and tribal outpatient departments are paid the Medicare outpatient hospital AIR for each encounter that provides outpatient services. And on an annual basis, the IHS calculates and publishes calendar year reimbursement rates. For calendar year 2024, the outpatient all-inclusive rate, or AIR, is $667 in the lower 48 states and $961 for Alaska. So IHS and tribal hospitals have continued to expand the breadth of services that they provide. Consequently, there are hospitals providing specialty services where the AIR might not be an adequate representation of the hospital's costs to provide services to people with Medicare. For example, the cost of providing a cancer drug, such as Opdualag, which is for the treatment of melanoma, has a per day cost of $28,975. That greatly exceeds the $667 payment an IHS or tribal facility would receive through the all-inclusive rate. This could be a significant equity and beneficiary access concern if IHS and tribal hospitals are not able to provide high-cost drugs or other services to the populations they serve. So, as I mentioned earlier, we're proposing to establish this add-on payment to the AIR for high-cost drugs. And as the cost of many specialty drugs exceed the AIR by significant amounts, the purposes of our proposed policy is to provide equitable payment to hospitals for these high-cost drugs when they're furnished in the outpatient hospital department. We anticipate that if implemented, this policy would have a favorable impact on health equity, as it would enable IHS and tribal hospitals to provide specialty services that require high-cost drugs to a historically underserved population. So for the methodology for this payment, we're proposing that a separate payment would be made under the through an add-on payment using the authority under which the annual AIR is calculated. Entities would receive the all-inclusive rate payment plus an add-on payment for qualifying drugs. And the proposed add-on payment would have no effect on the calculation of the annual all-inclusive rate payment amounts. So to qualify as a drug that receives separate payment under this proposal, a drug would have to have a cost that is 2 times the lower 48 all-inclusive rate. For 2024, this means that the drug would have to have a cost over $1,334 per day, or 2 times $667, which is the lower 48 AIR, in order to receive an additional payment. This threshold would ensure that the add-on payment would apply only to drugs whose costs significantly exceed the lower 48 AIR. And we think this threshold is consistent with a couple of other policies that apply under the outpatient prospective payment system, where there's what's known as the 2 times rule. So a particular procedure is required that the highest calculated cost for an individual procedure that is categorized to any given ambulatory payment classification can't exceed 2 times the calculated cost of the lowest cost procedure that is in the same APC. Similarly, there's an OPPS outlier policy that requires that the cost of a service that exceeds 1.75 times the payment amount for a service would qualify for an outlier payment if it meets the applicable criteria. So the proposed qualifying drugs. Any high-cost drug furnished in a hospital outpatient department of IHS and tribal hospitals that meet the following criteria would receive separate payment. If it's a drug that's covered under Medicare Part B, if the drug would be paid for under the OPPS, if it was furnished by an OPPS hospital, and if the cost of the drug exceeds 2 times the lower 48 AIR for 2025. Addendum Q in the 2025 OPPS ASC proposed rule lists the 325 drugs that qualify, that would qualify using the 2024 lower 48 all-inclusive rate as the cost threshold. And of course, we'll note here that in the proposal, we'd be using the 2025 AIR to calculate the threshold, which of course we don't know what that is yet. So for calculating the proposed add-on payment amount, we're proposing to price the additional payment amount for each qualifying drug at average sales price, or ASP. This is consistent with OPPS payment for most drugs, which uses the ASP methodology of ASP plus 6%, but recognizes that the IHS and tribal facilities primarily obtain their drugs through the federal supply schedule, whose rates are significantly lower than ASP. When ASP information is not available for a drug, we propose payment at wholesale acquisition cost, or WAC, and if unavailable, then we would use 89.6% of average wholesale price, or AWP. So for implementation of this proposal, the IHS's usual annual announcement in the Federal Register is in December, and this year would be December 2024, which includes the announcement of the lower 48 air for calendar year 2025. CMS would multiply that lower 48 air amount by the finalized threshold multiplier, which here we've proposed at 2, and then compare the result to the estimated per day costs of OPPS drugs. A list of drugs whose costs exceed 2 times the lower 48 air would be generated and then communicated to IHS and tribal hospitals prior to January 1, 2025. During calendar year 2025, IHS and tribal hospitals would submit claims for drugs included on this list and would receive separate payment. The list of drugs that are over the threshold would be updated on a quarterly basis, and that the sort of full process would be repeated on an annual basis each December when the lower 48 air amount for the following calendar year is announced by IHS. So this slide highlights a few additional comment solicitations that we included along with this proposal. So in the proposed rule, we saw a comment on setting the payment qualifying payment threshold at 1.75 times the lower 48 air instead of 2 times, and that would be $1,167.25 in calendar year 2024. To align it with the multiplier that we use to calculate the threshold for triggering outlier payments under the OPPS. We also sought comment on alternatively paying the add-on payments to IHS and tribal hospitals for biosimilars whose per day costs do not exceed the threshold, but whose reference products do exceed the threshold. And finally, we sought comment on paying for these separately paid drugs at ASP plus 6%. All the comments on this proposed rule must be submitted to regulations.gov before the comment due date, which closes on September 9th. At this point, I will pass it over to Sarah to walk through the next piece of the presentation.
Hi, everyone. I'm Sarah Shirey-Loso. I'm the director in the Division of Ambulatory Services at CMS in the Center for Medicare. I'll be speaking with you today about a request for information we have in this calendar year OPPS NP Notice of Proposed Rulemaking, and we are requesting information on a request to pay all IHS and tribally operated clinics the IHS Medicare outpatient all-inclusive rate. For a bit of background, due to a letter in June of 2020 from the TTAG, started these conversations several years ago to look at flexibilities that CMS might have to apply the outpatient all-inclusive rate under IHS to other clinics, tribal and IHS clinics. That letter focused somewhat on FQHCs, but upon further conversations throughout the last couple of years, I think we get a sense that it is beyond FQHCs, at least FQHCs under Medicare, and various sorts of other tribal clinics, practices, and facilities. In calendar year 2022 of the physician fee schedule proposed rule, we did have a comment solicitation. And following that, we were part of a work group with our colleagues in the Division of Tribal Affairs to continue to gather more information related to costs and the types of facilities that would be implemented by these changes, that would be affected by these changes. And then finally, what we're here to talk about today is because we initially requested information in the physician fee schedule, we know that the outpatient rule has a different audience, and so we wanted to also request information in this forum as well under the outpatient proposed rule. Great. So in the next couple of slides, what I tried to do is outline the types of information that will be helpful to us in your comment letters. First, we'd like to hear about any equity and or access concerns that clinics might be having due to payment rates that they currently receive under Medicare or otherwise. Second, we're interested in the types of clinics and facilities. I think we've heard a ballpark estimate of potentially 600 types of clinics. And I think for our perspective, we're trying to understand how those clinics relate to Medicare now. Are they physician offices or practices? Are they FQHCs in the Medicare sense, or FQHCs certified via HRSA? Are they provider-based or freestanding, or are they other clinic types? Any kinds of information on the types of clinics and facilities would be extremely helpful so that we can have a big picture. Additionally, any enrollment or billing information that can be provided from the prior slide. What of those clinics are enrolled in Medicare? Are they not enrolled in Medicare currently? If they are enrolled in Medicare, are they billing the physician fee schedule or Medicare under the FQHC PPS? Are they the grandfather tribal FQHCs, or are they billing another Medicare payment system? Finally, another question is, would the clinics seek to enroll as a Medicare FQHC if they are not already an FQHC, or if they are a physician clinic? Is that something that the clinics would consider? And finally, we're looking for any clinic costs and evidence that supports that the IHS outpatient air for all clinics is appropriate. Looking at did the cost of the services in the other clinics sort of equate to the clinics and facilities that currently receive the outpatient all-inclusive rate. And I believe that is the end of my slides. Just a quick overview, but really looking into answers to those questions and comment letters would be really helpful in us kind of understanding the big picture. And I believe back on slide 16, you can send your comment letters to regulations.gov by September 9th of 2024. So we look forward to your comments. Thank you.
Thank you. Now is the time to ask questions. I see Elliot has raised their hand.
Wonderful. My name is Elliot Milholland. I'm with Hobbs, Strauss, and Walker, and have worked with a number of tribes on both of these issues. Want to really commend CMS for including both of these proposals in the proposed rule. I think you'll be getting a lot of tribal comments in support of these proposals. I do have a question on the high-cost drug rule. Just to clarify some information that was provided in the rule that I hope that Mr. Rice and your team, you might be able to address here today as we start preparing comments on the rule. So as we understand the proposal currently, the CMS Medicare would be making an add-on payment for high-cost drugs that exceed that 1334 threshold, which is twice the all-inclusive rate for the lower 48 states. And in order to determine whether or not a drug exceeded that threshold, you would be using the average sales price of the drug in order to do that. And then if a drug exceeded that threshold, the tribal healthcare provider would receive the all-inclusive rate plus the average sales price cost of the drug, as we understand the rule. And there's some questions as to whether it should be average sales price plus 6%, whether the threshold should be slightly revised. One thing that was very helpful was the addendum Q, the Excel spreadsheet that you provided along with the rule. And in that Excel spreadsheet, it indicates in the column that in column C, there's something called payment rate. In the title of addendum Q appears to indicate that payment rate is the amount which the cost of the drug based on the average sales price exceeds the all-inclusive rate, or exceeds twice the all-inclusive rate, I should say. Is that correct? Is that what that means? It was unclear what the term payment rate meant in column C in the addendum. So perhaps if you could speak a little bit more to the specifics of that, it would be helpful for folks as they are starting to assess the rule and developing comments for it. Thank you very much.
Sure. Corey, do you think you could walk through addendum Q for folks to help answer that question?
Sure. Yeah, this is Corey Duke with the Division of Outpatient Care. Yeah, thank you for your question. Just to give a little bit more detail about addendum Q. So yeah, so this lists the qualifying drugs that was modeled based on 2 times the 2024 error. So drugs that would have a per day cost that exceed that threshold. And as you mentioned in column C, there is a payment rate column. Now this is the payment rate per HCPCS dosage unit. So you may notice for some of the codes, they are, the certain drug one, and then it will have like a 1 milligram next to it. So the payment rate would be per 1 milligram billed. But a patient may receive 100 milligrams, so then the payment rate would be 100 times, or excuse me, the total payment rate would be say 100 times the payment rate listed in addendum Q. And if that okay, I was gonna say, and if that doesn't make sense, I can go through a couple more examples, but yeah.
That would be helpful, actually. I think we may have some pharmacists on the line. I'm not a pharmacist, so somebody from on the pharmacy teams might want to chime in here and ask some additional questions about exactly what that represents. So you're saying that payment rate, because obviously if you look at the first line in addendum Q, line 6, it's for rabies, and the payment rate is $269.48. That obviously does not exceed the AAR, which is 1334. 1,013.34. So I just trying to figure out the correlation. Is that the amount that it is above the 1334, or is you're saying maybe that's because it's not the actual dosage, it's a per unit dosage that doesn't actually. I'm trying to figure out how the apples, are we talking apples and oranges, or exactly how this works?
Right. Yeah. It's that second bit that you mentioned. The payment rate is the amount that would be paid per unit billed. So for a lot of these drugs, there could be, and likely will be, multiple units of the drug billed, depending on how much drug that the patient receives.
Understood. Okay. Thank you very much.
Yep. Yeah. No. Thank you for your question. And if there are any other questions, please let us know.
Thank you. Kyle has their hand raised, and they also put a question in the chat. So if we could unmute Kyle's line, you should be able to speak now.
Good afternoon. My name is Kyle. I'm an oncology pharmacy coordinator in Tuba City. I have a question very similar to just asked, but I give an example there to make sure I understand it correctly. For example, for the Abdullah, the dose is 240 milligrams per 80, and per unit dose is 3 milligrams per 1 milligrams. And the payment rate in 2025 is 176.42 cents. But the patients got 240/80 milligrams every time they got infusions. So the payment they're gonna compare to the 2-time air gonna be 15,239.60 versus the 1,344 that is 2-time air for 2025. Is that correct?
Right. I believe what you described is correct, but let me restate it. So yeah, so the drug that you identified, the payment rate in the addendum was $176.42. And that's per the 3 milligram/1 milligram build. And then if the patient received 80 times that amount, so 80 units were billed, then yes, as you described it, that $15,000 number would be the additional payment provided.
Okay, thank you. And then I have a follow-up questions. So some of the oncology medication high cost, that is single dose vial. Let's say the drug A is 100 milligrams, but the patients only get 50 milligrams, and we have to dispense the entire vial. How the ASP going to compare to the 2 times higher than the air rate?
Right. So the per day cost will be calculated based on historical claims data for the units used. I think if there's any recommendations on the specific situation that you're describing, I think we'd be interested to hear that in the comments as well.
So yeah, so maybe just to clarify, because I think Corey makes a good point there about there's sort of 2 different frames of reference here. The first is what drugs qualify for separate payment. And we do that analysis looking at the per day costs of the drugs using historical data and whether or not that is greater or less than or equal to or less than the qualifying threshold, which was proposed at 1,300 or proposed at 2 times the air, which using 2024 rates would be $1,334. The second part is what is actually paid for the drug when it's used in 2025. And that's where sort of the calculation that you all were just talking about, the amount of used by the per unit payment rate is calculated. So, once a drug is determined to be above the threshold based on its per day costs using historical data, you don't look at the comparison to the air again for that drug. That drug for all of 2025 will be separately paid when used, and the payment rate will just reflect how much is used in 2025.
Thank you.
Great. We have another question in the Q&A box. Will this proposal impact Medicaid air reimbursement methodology for meds with the same issues in any way directly or indirectly?
So I think the question is, does the drug proposal affect the air payment rate for 2025? And the answer to that would be no.
We have a question that just came in. Will the slideshow be posted? And I can answer that. In the near future, we will be posting the recording of this webinar on the cms.gov website. Another question we have is, how do we find the RFI on regulations.gov? Great, thank you. And then we have Kyle has their hand raised. If we can go ahead and unmute their line.
Good afternoon. You mentioned that earlier that the proposed new payment for 2025 going to send to tribal and IHS. My question is, who do you send it to for the tribal and IHS? And how we obtain that as a specialty care center or oncology center?
I'm sorry, I wasn't quite understanding the question. Could you rephrase
Yeah,
that?
yes. Yeah, I just want to clarify that you mentioned earlier that the proposed new payment the list gonna send to tribal and IHS. Who in the tribal and IHS you're gonna distribute it to? So who is the receiver that we can reach out to obtain the list of the medications?
Yeah, so for one, it would be posted on the CMS website. As far as the how it would be distributed through IHS, I'm not sure I could answer that at the moment. I don't know if anyone else could.
We can find it if it's posted on CMS as well.
Yeah, it would certainly be posted on the CMS website as part of the final rule, and then we as an addendum Q to the final rule, and then if there's when there's an update to that using the 2025 AIR, we would post that on our website as well. But I believe IHS would also make sure the list is distributed as well.
And this is Kitty Marks with the Division of Tribal Affairs. We can work with the Indian Health Service to distribute that list when it becomes available. Thank you.
Thank you. We have another hand raised. If we can go ahead and unmute their line.
Hi, this is Joette Walters. Thank you for acknowledging my hand raise. I didn't realize you didn't have my name on the list. Yeah, I am from Tuba City Regional Healthcare Corporation. I really appreciate CMS's work on this. Thank you, and I recognize Ms. Marks. Thank you. But I think Kyle, our pharmacist, did already ask this question. I just want to ask again for clarification. One, it does in the proposed rule, it does state that a list of drugs will be generated, those drugs that qualify, that have met the threshold. That list will be generated, and if I understand correctly, will be posted on the CMS website. I think, again, our question is, just for clarification, how then does a 638 tribal facility obtain that list? I guess that would be something we'd still need to work out. Who would I, as the CEO, expect to receive that list, or does that go to the pharmacist or our revenue cycle billing team?
Yeah, so again, it would be posted on the CMS website. As far as how it would get distributed through IHS, I think as Kitty mentioned, they'll sort of follow up with that, and we can certainly make sure there's additional description of that in the final rule. If that you want to submit a comment on the proposed rule, that this is sort of an area of interest, we can try to include additional description in response to that comment in the final rule. Kitty, I don't know if there's anything else to sort of say on that at the moment.
No, I think that we can work that out. Like I said, we can work with Indian Health Service to distribute it through the CMS Tribal Technical Advisory Group. And our division also maintains a separate American Indian Alaska Native website. So sometimes it's easier to find information on that website since it's more discreet. The cms.gov I know can be kind of hard to navigate. So Joette, thank you for your comment, and we will certainly work with Tuba City. Glad you're on the call. Thank you.
Thank you.
Thank you. If there are any other questions, please either raise your hand or you can place them in the Q&A box at the bottom of your screen. We have a question that just came in. Is there a list of participants or tribal affiliations from this webinar?
Yeah, this is Kitty Marks. Again, KAI maintains a list of participants. Are you asking about, and Thomas Brown looks like he's answering this question.
Right. At this time, I'm not seeing any additional questions come through. So Beverly, I'll hand it back over to you.
Thank you so much. Thanks, Michaela. Thanks, everyone. Thanks for having such a great consultation webinar. Thank you, David, and thank you, Sarah, for that overview. Thanks for all of the questions. Just always also want to remind you that the comments and the requests for information are due September 9th, as David and Sarah mentioned. You can also, the link to submit comments is linked here in the chat or Q&A section, in both sections. And then you also can find that link in the save the date notice. If you want to go back and look at the save the date notice, you can find that link as well. Just want to thank everyone for their participation in this webinar. Want to remind you that a copy of the webinar will be found on our spotlight page of the American Indian and Alaska Native Outreach and Education website. Again, that website is at go.cms.gov at go.cms.gov/AIAN under all tribes calls. And as always, you can submit any inquiries to the CMS Division of Tribal Affairs mailbox. That mailbox is at tribalaffairs@cms.hhs.gov. I'll repeat that. That is tribalaffairs@cms.hhs.gov. And with that, I hope everyone has a great afternoon.